like Mimi, I'm glad to be here with you all today. I'm different from Mimi. My looks may reveal that I've been a participant in discussions like this, several of these discussions like this for past 30 or so years. And it is an exciting time for those of us in the healthcare area because of this new law. Throughout my career, I've always started off my classes with my students talking about how in this country, we've agreed for 30, 40, 50 years that our healthcare system is broken and that it needed to be reformed. But my first premise about that we all agreed that our current healthcare system is inadequate. You're not going to hear that kind of agreement on Fox News or MSNBC News, right, at night, because you're just political. But professionally, those of us who have studied our healthcare system, those of us in the industry practicing, we've all been frustrated for so many years by the huge problems with our existing healthcare system, our very rapid cost increases exceeding the rest of the world, our high uninsurance rates, our access problems of all kinds, and the paperwork and the bureaucracy that is. So we all agree. Question is this the answer? It's probably not the answer. The ACA is, I think, the most insightful comment I've heard over the past year or so in conferences I've attended on this is the first big reform initiative, perhaps, in the next 30 years. We're going to play with this thing. It's going to happen, parts of it, no matter what happens in the election this fall. And then we're going to find things that are totally inadequate and unacceptable. And even those who, whatever side of the aisle, whether you're an advocate or a critic, you're going to be on the other side of the aisle a year from now on some of these issues as we unfold this comprehensive bill. What I'd like to talk about briefly, Mimi has set me up very well by giving you the hard part, some of the history and the big picture. Basically, in my mind, it boils down to the two large issues. One is there's a whole bunch of things in this law about coverage, about extending coverage, and then there's a whole bunch of things in this law about changing the healthcare delivery system. So I'm going to go over very quickly the key coverage provisions, some of the key coverage provisions, and the healthcare, and then how it's at this early stage, how it looks like it may have effect on the greater Houston area. And let's see if I can make this work. This arrow says it should go forward. It did. Oh, great. So. I'll start off with the key ACA provisions respect to coverage. And Mimi has mentioned a few of these already. Basically, probably most controversial in this whole thing, come a year and a half from now, all of us are going to have health insurance coverage or pay a penalty. This is the individual mandate. We've never been told by our government that this is that we're going to have to get this and pay a penalty. Very controversial. There's all kinds of reasons why this mandate has to be there to make this system work. We'll probably touch on a few of them today. It eliminates lifetime and annual benefit limits on health insurance. Lifetime and annual benefit limits cannot be capped by health insurance carriers. It prohibits pre-existing conditions exclusions. So the healthcare industry, health insurers cannot charge people higher premiums for poorer health. It allows dependent coverage up to age 26 on parents' plan, and it requires coverage. All health insurance plans must provide preventive coverage and eliminates out-of-pocket expenses for preventive services. So this bill tries to move us in the direction of more preventive-oriented and wellness-oriented in our health financing, our health insurance plans. And I think there's about 16 of these preventive services, and for adults, there are things like mammography, colonoscopy, colorectal screening, HIV screening, depression screening, etc. trying to get us, provide us with a financial incentive to keep up with ourselves on these things with our doctors, and we don't pay anything, and our plans must cover and pay these things to get us more oriented toward preventive services. So in a nutshell, those are the big coverage changes with respect to health insurance reform. The second big coverage change is the creation of these things called exchanges. And this is the thing that is supposed to solve all the problems in our individual health insurance market, which is totally broken. Our big group health insurance market isn't as broken as our individual one in terms of high premiums, difficulty in getting good coverage, stability in terms of maintaining coverage, and so on. So we were going to set up these exchanges, which are supposedly going to be marketplaces for individuals and small businesses, where there'll be a limited set of health insurance products that supposedly will be sold to us who are buying insurance in the individual market in a way that we can understand and figure out what they can do for us and what they can't, and make an intelligent choice. The Texas governor, as Mimi said, is opposed to a state exchange. So it looks like Texans will be signing up for the federal version of the health insurance exchange. All right, and within these exchanges, when you go to these exchanges, if you are a lower middle income person, that is, if your income as an individual ranges from about $11,000 a year, poor, $44,000 a year, middle income, or if you're a family of three, about $20,000 up to about $74,000. If you're buying insurance on your own in the individual health insurance market through an exchange, you will get help from the federal government to buy that insurance. There'll be a tax credit that will be quite generous if you're very poor, and then will be less generous as it goes up to $60,000, $70,000, $80,000 a year in family income. All right? All right, and then, so that's the exchanges. And then the other big coverage thing is this big expansion in Medicaid. And this Medicaid, this public insurance program that we all love and hate, is going to become about 50% bigger than it is now if we fully implement the ACA. It's going to go up to 133% of the federal poverty level, and that's for the lowest incomes folks, the individuals making less than $14,000 a year, family of three making less than $25,000 a year. They'll be in here, they'll be covered. It's voluntary, but again, we go back to the individual mandate. If you stay uncovered, you will pay higher taxes in the form of a tax penalty. All right, so that is the exchanges. So those are the big three. In a nutshell, it's much bigger than that, thousands of pages. But those are the health insurance reforms, few that I've highlighted, the health insurance exchange, and the Medicaid. All right, the impact. Very quickly. I've projected out for the Harris County and all of the surrounding counties, and going south, Brazoria and Galveston County, it's about a 13-county region. We currently have 4.2 million people insured in this region, this 13-county region. If ACA gets fully implemented, based upon reasonable assumptions about population growth, reasonable assumptions about people taking up these programs that are being offered to them, we're going to get an increase in the number of people covered in Southeast Texas from about 4 million people now to almost 6 million people between now and 2020. Can you imagine? 2 million more people with health insurance coverage, with a ticket to ride to health care, with access to health care coverage. It's a huge, huge thing, this is. A big part of it is Medicaid. I said it's going to increase. Right now, Medicaid in this region covers about 730,000 people. So that's already a big number. In 2020, if we get fully implemented ACA and we get the expansion in Medicaid that right now our governor is not supporting, but who knows how that's going to end up, we would have 1.3 million people on Medicaid in Southeast Texas by 2020. We currently have 700,000. It would be 600,000 more people would be in Medicaid. All of us who are doing health care, we will be participating in the Medicaid program. And then the enrollment exchanges, which is 0 now, by 2020, if they unfold, we'll have almost 500,000 people in exchanges. Okay, so I'm going to skip. So that gives you the, I think I've given the bottom line message. It's big. It's going to potentially benefit a whole lot of people. Other big point is it's going to cost a lot of money. This is just a quick introduction to it. The Medicaid program expansions alone are going to cost us about $2 billion more a year of state taxes that we're currently paying. About $10 billion, though, of federal dollars is going to roll into the state for the Medicaid expansions. The federal government is picking up most of this Medicaid expansion, but we will still have to pick up a significant portion. Medicaid program in total will grow from a $35 billion a year program to an almost $50 billion a year program by 2020. All right, and okay, so that's the coverage. I wanted to make one more point, and that is on all the other 800 pages of this bill is about health reform. Trying to get our healthcare system to be more efficient, more prevention-oriented, more primary care-oriented. Very quickly, the major provisions, incentives for primary care medical homes. What the ACA is trying to tell doctors is we would like you to come into groups, small and large groups, primary care doctors, and extend and enhance and beef up your services tremendously in those medical homes. Provide after-hours call and coverage, make yourself readily available, have all kinds of electronic record keeping, and be able to follow your patients into the hospital, out of the hospital, continuity of care, all that stuff. We've been talking about this for years. It's been, we've tried it in many different models. The new one is the medical home. We're trying to move away from fee-for-service payment in our healthcare system. It's inflationary, it's not efficient, leads to fragmented care. Bundled payment, where we get people, our providers, to take a fixed payment for a delivery, a fixed payment for a surgical procedure in the hospital. Accountable care organization, demonstration projects. These are projects trying to get providers to integrate. This is the modern version of HMO, health maintenance organizations. Only it's different. Maybe we'll probably touch on this in some detail. ACO. Medicare payment rate reductions. The biggest source of paying for all the coverage expansion is going to be that the ACA projects out that with all the efficiencies that we're supposedly going to get from these reforms, Medicare costs will not rise as projected. We've said that's going to make it. We're going to make that happen. And that's what the $500 billion out of this $1 trillion price tag on this bill comes from, is projected Medicare cost increases won't be as much because we're all going to, in the healthcare industry, get efficient. Okay, and I think I will very quickly, I don't know very much about what's going on in Houston. It's too soon. Two healthcare provider groups have signed up to be ACOs so far. Memorial Hermann has a physician group that has signed up for it. There's another group that has done it. Harris County Hospital District, our safety net system, that we pay local taxes. This is the way we fund indigent care now, right? Is we pay local taxes to the Harris County Hospital District, and we have about 17 clinics and 3 hospitals that provide care. They are very nervous because all these folks are going to be on Medicaid. So what are they doing? They are adding clinics. They are building an outpatient specialty center. They are becoming medical homes in their clinics. Ben Taub and LBJ, which have 4-bed rooms, they're moving them to 2 bedrooms. They're trying to get competitive in order to keep these patients once they get on Medicaid.